Thank you, Dr. Sangeet, for including me in this presentation. So I'll be showing three different cases. This was a 35-year-old gentleman who came from Uzbekistan. He had undergone right eye vitrectomy with silicone oil injection for myopic retinal detachment and underwent silicone oil removal, and he had a macular hole now. In the left eye, silicone oil was still there for myopic retinal detachment. It was 5000 centi-stroke oil, which we realized when we planned vitrectomy for this patient for macular hole. He had cataract, 5000 centi-stroke oil in the left eye with a macular hole. So it took us almost 45 minutes to take out the silicone oil. It was quite thick silicone oil, and then we started with the surgery for macular hole. We stained with the first with brilliant blue, but couldn't stain much. Then with the ICG, and we could stain the membrane, and you can see we are able to take out the internal limiting membrane, but we didn't have long forceps. It was highly myopic eye, and the view was getting distorted again and again. So surgery was getting prolonged, and you can see the membrane is quite adherent, and the instrument is getting stuck to the recite lenses. So we changed over to lender lenses, and even with lender lenses, it was so difficult to reach up to the posterior pole. And though we were able to take out this intermediate membrane bit by bit, but even then it was becoming difficult. The view was very hazy for us because the lens was still not giving adequate visualization. And then we tried with Tenno scraper also to just bring the internal limiting membrane towards the macular hole, and to some extent we were successful. You can see the internal membrane is coming towards the macular hole. So surgery was basically getting prolonged, such a highly myopic eye, and going on with all this instrumentation. And then we were just going to close this case, and then suddenly we realized that we are landing up with suprachoroidal hemorrhage. And you can see the big mounts developing over there. So immediately we did fluid aid exchange, and this was limited suprachoroidal hemorrhage. And this is the picture. But next, the patient was having vitreous hemorrhage, and the choroidal hemorrhage mounts were increased. So we waited for another next 12 to 14 days, and when the ultrasound showed suprachoroidal hemorrhage liquefaction, then we drained this. We planned for drainage of this fluid. So we are making anterior corneascleral opening and putting AC maintainer. And usually what I do in my suprachoroidal hemorrhage, I just make sclerotomies at the usual place and try to drain the blood from there itself as much possible. And you can see the blood usually comes out of these sclerotomies. You don't have to go over the site of the posterior site where the hemorrhagic mounts are giving maximum elevation. You have to be a little patient, and you have to maintain the pressure. And I was a little wary also, because last time choroidal hemorrhage developed, so this time I just wanted to finish the surgery as early as possible. You can see thick blood is there in the vitreous cavity, taking out with the suction of the vitrectomy cutter. Now we're going with the back flush needle active aspiration, and you can see now the retina is becoming visible. So this is the point I stopped. You can see the mounts have grossly reduced with this anterior drainage only, and now I'm making another sclerotomy where I could see some hemorrhagic mounts were there, and now drained the blood. So this is how you could drain the blood, and you can see the red glow is coming back. So the patient, this macular hole was closed in this patient, and this is how we could manage this case without going posteriorly over the choroidal hemorrhagic mount. Next patient is diabetic vitrectomy for combined retinal detachment, and this patient had a combined retinal detachment. We are going ahead with vitrectomy, and you can see a thick prolif attached to the optic disc and going nasally and causing combined retinal detachment. We are going with the cutter. We tried to peel off this posterior violet phase from the disc towards the periphery. You can see it is quite adherent, and we don't have any counter traction there. So just trying to take out with the cutter. Then we thought of putting a chandelier because it was not possible to go ahead with the case. And you can see the membranes are quite tough, holding with the forceps, gripping forceps, and going with the intraocular scissors to find the posterior hallular phase and just trying to release the traction from the retina. So you can go inside out, outside in, wherever you can find the plane. And very important to find the plane, otherwise you are going to land up into more and more bleeding in such cases if you are not in the right plane. And once dissecting with the forceps, then you can see you have to be really gentle, and then you can go with the vitrectomy cutter to take out the membrane. And then so this is how there's no counter support from the retina, and going with the vitrectomy cutter and draining and cutting all the proliferation. And this is quite extreme at the extreme periphery. Going with the fluid air exchange and settling the retina. You can see the retina is nicely settled. And then going with laser and putting the retina back. So this is how the retina attached. Third patient, again, myopic pediatric retinal detachment with PVR. Boy was just 12-year-old and he was from overseas. This was a picture having cataract, posterior synecdoche. So the view was not clear, so we just went with the one with the fluid needle infusion, and with the other hand we are just doing the lensectomy, because we are not sure whether if we are putting the cannula, whether we'll be able to see the tip of the cannula. And then after putting the cannula, we realized there is choroid over the trocar, so just remove that choroid, and you can see this was total retinal detachment, open funnel, and there was practically no vitreous. So we are just trying to peel off the membrane. We had gone toward the posterior pole, but couldn't see much, so just stained with the brilliant blue and trypan blue dye. But even that couldn't stain any of the membranes. So we are just trying to peel off the membrane. These were kind of very immature membranes, but they were over the retina. Dissection is going on, but we didn't put any belt buckle in this case because we had anticipated, because we'll have to do some relaxing retinotomy in such case, so we didn't plan for any belt buckle. Then we are putting the silicone oil over the posterior pole, and you can see the traction is still 360-degree around, and trying to peel off the posterior hallular face with the end gripping forceps with the cutters, just trying to peel it off as much anterior as possible. And these membranes are still tightly adherent, you can see, and the retina is bleeding at few places. And once the membranes was dissected to the maximal, then we are doing endocautery. And then with the vitrectomy cutter, we are just doing 360-degree relaxing retinotomy. And then cutting the anterior retinal flaps also up to the ora serrata. And just checking whether any membranes are subretinal or not. So it was just primarily a pre-retinal proliferation which was there. And then with the biomanual way, we're just trying to stretch the retina 360 degrees so that the edges of the posterior retinotomy, they remain free. We are putting silicone oil, PFCL. You can see the retina has nicely flattened. And we are doing laser 360 degree. And it was followed by silicone oil PFCL exchange. And you can see the PFCL is being taken out and the retina is attached. So this is how we could manage this case of pediatric retinal detachment. And then we always close the sclerotomy because he was a young male, and the sclerotomy is because of scleral rigidity, they keep leaking. So it is always better to put a suture. Thank you.
Thank you, Dr. Neeraj, for the